Hello, everyone. I am so excited. Look, let's be honest. I'm excited every Tuesday when y'all are here and we have a presenter and a fabulous webinar just a few minutes away. But I'm super excited today because we have my very good friend, Dr. Evan Gwilliam. What can I say about this man other than I just positively, absolutely adore his brain, because this man knows so much stuff and he is like my go-to guy, well, for pretty much everything. I've had the great pleasure of traveling all over the country with Evan, hearing him speak to audiences. Once we broke GoToWebinar, which is why we have the current platform, because simply so many people were interested in what he had to say. He is fantastic. He is a graduate of Palmer College of Chiropractic, was a valedictorian, which is no surprise. He is a certified professional coding and ICD-10 instructor, medical compliance specialist, certified professional medical auditor. He's just the man. And he's a sought-after seminar speaker, again, all over the country, and provides expert witness testimony, medical record audits, consulting, and online courses for healthcare providers, has authored and contributed to reference books and articles for multiple publications. Like I said, he's my go-to guy, and I am so excited to have him here talking about the perfect soap note. And apparently all of y'all were too, because we had record-breaking registration numbers for this presentation. So without further ado, Dr. Evan Gwilliam, thank you for being here today.
Thank you, Christy. It is always my pleasure, and I thoroughly enjoy presenting and working with ChiroHealthUSA and working with you and Dr. Foxworth. I think that you guys are fun folks too. So I'm here kind of wearing a few hats today. And those of you who've heard me speak before may have heard parts of this presentation before. But when I was asked what topic I could present on, this is just so critical and has so much action-packed information for you that I really felt like this was what we needed to discuss today. Without further ado, this is the perfect soap note we're going to discuss. And I created this title in an attempt to mislead, because the idea of a perfect soap note is the concept that it works with everyone, and every reviewer and every insurance company and everyone else would go, yeah, this is great, and everyone would agree. And that's just not going to happen. There are parameters in different groups, and I'll talk to you about some of them, who feel that some things should go one way and some things should go another. So my goal is to provide you with a pathway to make sure that your records are good for most, okay? And that would have been a much less exciting title. The good for most soap note, So I'm going to give you my perspective as a guy who is a chiropractor, a clinician, but also an auditor and a coder. And I want to bring that to the table here, because I need you to see how you can convey information to outsiders so that they don't have a cow about what's in your records, okay? And that's my goal with you today. I have sat through plenty of seminars in my day that were not worth my time. And I've done webinars where I'm working on other things on my computer and I'm sleeping and I don't hear, and I'm just there to check in and check out. I do not want to do that for you guys today. All right, I'm going to make this as lively as I can, and I'm going to give you nuggets and good little bits of information and detail and useful stuff. Okay, that's my intention. So I am the clinical director for PayDC, which is a chiropractic cloud-based EHR software that is very, very focused on compliance, which is why I'm the clinical director. And so if any of you are looking at a documentation, scheduling, billing solution for your office, there's my email address, okay? And please talk to me about it. But I also used to work with ChiroCode. For those of you who know me from ChiroCode, I was there for 6 years as the vice president of ChiroCode, and a lot of what I'm sharing with you now, I wrote into last year's edition of the ChiroCode Desk book, which is a great reference you should consider. I am completely unbiased when I recommend it because I don't work for them anymore. But I think at the end of the slides, I'll give you a coupon code if you want to go out and order a copy of the latest desk book. It has most of what I'm sharing with you in that book, okay? And I'm sure you can get to this recording and rewatch it as well. But so there's all these options. I also want you to know that we do work with ChiroHealthUSA at PayDC. We help them with compliance questions and issues. When we have people who are having trouble figuring out what their fees should be, we can help with that. We have reference materials and experts on our crew that can help with those things. So got some great relationships there. Here's what we're going to do today. We are going to, I have really two takeaways for you. I want you to understand what payers are asking for in terms of SOAP notes. And I'm going to use SOAP notes to describe treatment or subsequent visits or daily visits more so than an initial encounter. Initial encounters are a little more robust, and I think that they can be done in the SOAP note format, but they need to be reinforced. And then I'm going to take a few minutes towards the end of this presentation to discuss how SOAP can fit with Medicare or CMS. Those of you who are into this stuff may realize that Medicare has no guideline anywhere that I'm aware of that says you should use SOAP notes. Medicare's never mentioned the concept of SOAP notes. And so I'm going to talk to you about how to correlate Medicare's requirements with the concept of SOAP so that you don't have to feel like you have two different kinds of notes. That is, notes for Medicare patients and notes for other patients. I want you to just have a SOAP note that works for everybody. Your cash patients, your insurance, your auto accidents, I don't care who they are. You should have a good standard SOAP note that meets criteria that would be scrutinized by a regulatory agency, a state board, Medicare, anybody. We'll talk about it a little bit more, but the idea that SOAP, if you haven't heard of it, for those of you who might be new on this call, it's an acronym that stands for the things that you should document at a typical daily encounter for healthcare. This isn't used just in chiropractic. It's a healthcare thing where notes can include SOAP. It stands for Subjective, Objective Assessment, and Plan. And so we're going to dive into those things in great detail, okay? But first, I have a little disclaimer for you. I think, there it is. This is my perfect SOAP note, not anyone else's. So if you guys are listening to this and you go, well, that's dumb, or he's wrong, go ahead, put it in there, put it in the comments. We'll discuss it, okay? We're going to leave some time at the end. Let's talk about it. Let's debate. I am not the only person who knows how things should be done. All right, I have some ideas, and I want to share them with you, and I've worked hard to, come up with what I've got, but I don't think I'm the only one who knows the answers, all right? I have some suggestions, and if you guys can help it get better and you can suggest something that will improve on what I've said here, I'm open to it. I'd love to share that with you. So I want to just briefly introduce this concept. I'm not going to spend too much time on it, but this is what I call the episode of care journey, all right? It's a journey during an episode of treatment for a musculoskeletal or really for a chiropractic-related condition. In the upper left, you have an initial evaluation, and on the lower right, you have the discharge evaluation. And then you have all the stuff in between. So you have a patient who shows up at some point at the beginning of a journey, and they follow a pathway to end up where they get released, and hopefully they're better off. In other words, they reach the destination. So this is supposed to be a roadmap you're looking at here on the screen. So you travel south on Spinal Stenosis Road for 4 treatment visits, and then you turn left on a Disc Degeneration Highway for another 5 visits, and then you reach a point where you need to decide if you're going to continue to go straight or turn south again on 2 different pathways. And those are all treatments that get you there, and eventually you reach the end and you discharge the patient, hopefully having reached their goals. So I want to make it clear to you that today I'm focusing on those treatment visits, those in-between points, more so than I am on the evaluations, which I think are different and need to be documented in a different way. Okay, and this graphic was designed for the ChiroCo Desk Book last year before I left that company. So I think it helps you understand in a way for you to look at your notes and what you're trying to convey through them when you try to communicate with third parties. Again, this is partly why I switched and started working for an EHR company, was because I wanted to be able to provide the answers instead of just explaining what people need to do. And so at PayDC, we're able to incorporate this very clearly, and it provides a great solution for our clients. So what I'd like to do now is take you through different requirements from different sources, okay? So daily visits or treatment visits or subsequent visits according to Medicare or just a typical SOAP note, this is what Optum says. Optum is the company that owns United Healthcare, okay? And so if you do work with United Healthcare, this is their requirements for you in your daily visits. They have said that there should be 4 things in a daily visit. Number 1, a subjective record of the patient complaint. Number 2, physical findings that support that the patient needs manipulation. 3, an assessment of change in the patient's condition. 4, a record of the segments manipulated. So these are the things required by Optum. And so if Optum says that these are things they need, then you would have to go out of your way to make sure an Optum-related record says these things, right? Well, that's fine, but what about this one? If you're in Colorado, they have this thing called Rule 22. It's in their statutes, the state statutes. It says established patient visits should have these 5 things documented. So they have 5 instead of 4. And I've kind of, this is literally a clip. I clipped this right out of the Colorado guidelines, and you can see it matches SOAP. It's got subjective, objective, assessment, and plan. And they add a 5th one, procedures. And most resources you look at now that talk about the idea of SOAP notes, they include 2 P's in SOAP, SOAPP, plan and procedures. And that's precisely what was done for Colorado. So they said we want the subjective information, objective findings, and assessment. And notice it says under number 3, it's not necessary to update this category every visit. However, we really want to know, if their diagnosis changes. This is where you would discuss their prognosis. Are they progressing well? All that. And then 4 and 5 is we're in a plan. We're following it. Everything is good, but we changed this part of the plan today because of this situation. That's where you would mention those things. And then the 5th element they want is, what are the procedures that are done here? You did e-stim, you did chiropractic manipulation, you did some exercises. This is where time would be recorded and so on. So that's the requirements for one state board as an example. So I showed you a private insurance company, a state board. Here's another one. This is a provider network that I did some work with in the Midwest. These guys are a provider network that manage chiropractic networks for a couple of healthcare plans in Minnesota and Wisconsin. And they gave me this and said, help teach our clients. And they came up with, there's actually 9 things. So this is just the first half. They said specifically, daily visits should include patient identification. Okay. Date of the encounter and a visit number. Interesting. Chief complaint, updated patient-specific measurable subjective and objective attributes. That number 4, that one's pretty loaded. There's a lot in that. Let me go on, though. Number 5 is an assessment of functional changes. And I want to emphasize this word changes. We're going to focus on that further in here in this presentation. Number 6, a current diagnosis. 7, the procedures. So a description of the procedures. So location, rationale, time, what the procedure is. So it's not enough to say I did manual therapy. You got to say, why you're doing the manual therapy, where you're doing it, what was it, what kind of manual therapy, all that. And then 8 is the plan. And I think it's important to put in the plan the next treatment date and the next reevaluation. I think those are very helpful to have in daily notes. And 9, the provider ID and signature with date and time. So these guys are a little more thorough, right? And some of you are looking at this going, well, those are all kind of the same, aren't they? Or maybe they're not. Maybe they're a little different. I think that there's some differences there. So what I'm going to try to do for you is help you. If you had these 3, if you were in Colorado and you deal with Optum, or you were part of this other network and you had to create notes, how could you create one note that satisfies all of these parties? How can you create the perfect SOAP note? All right, that's what we're trying to do today. So I'm going to do that for you. At the end, I'm going to give you a template that I think captures all that is required by all those entities, okay? And again, I'm not perfect. I might miss something here. So you guys can chime in and we can have it out. I'm happy to debate, especially when it's one-sided here and I'm the only one who gets to talk, right? So SOAP notes. This actually came about in the late 60s as part of this this initiative started by a medical doctor who published a paper about problem-oriented medical records, and said that problem-oriented medical records should have 6 elements, and one of them is a SOAP note. And so this has been around for a long time, and it really is the accepted standard across all of healthcare. You got subjective, objective, assessment, and plan, and then I've added procedures here because it kind of fits there under plan. You describe where they are in their plan, and then you describe what procedures will perform that day. So it's SOAPP if you wish. Now, before I dive into the specifics of these, I want to show you an example I got from a Medicare contractor. And I want to warn you a little bit here about cloned records. These are clipped out of a document that was published by Noridian. Noridian is a Medicare contractor in mostly the Western United States. And Noridian came out with this article, gosh, at least 5 years ago, I think it was. And they said, we know when chiropractors are cloning their records. Here's some examples. Because I have these doctors who tell me, well, if I use EHR, then what if, the notes and I don't change anything, is they're the same? I go, yeah, they're the same because the patient's the same. If you just do a word spinner or a random text generator, you are not creating new notes. You're just spinning words around. And Medicare gave these examples to show that they can see it. They know, and you're not fooling them. So these are examples of subjective and objective documentation that they believe were cloned, even though the words are different. So if you just look at the first two there, the first one at the top says, day 1, the patient is troubled by a moderate grade of intermittent dull pain with stiffness and soreness in her head on both sides. Day 2, it says, in both sides of her head. So they took that phrase and moved it to the beginning of the sentence instead of the end. She is afflicted. Instead of troubled, they said afflicted, moderate grade of dull pain, and they put intermittent at the end of the sentence instead of the middle. I mean, so they just spun the words around, okay? Spinning words is not a new note. You got to figure out how to convey changes and information in these SOAP notes. So I will show you how. I just want you to see here that payers know when we're trying to trick them into thinking notes are different, okay? These notes are not different. They're just words moved around, okay, using a few synonyms. That's it. So how do we solve this? Well, I'll get into it, I promise. I'm going to let you sit on that and think that there's no solution for a minute, though, okay? Here's one way. This is an example of a snippet out of just one of the notes from PayDC, from our software. And here's an easy way to emphasize change. We put them in bold. So it's really simple. You see a couple of phrases in bold there, decrease to 6, occasional, and decrease to 4 at the end. Those are all things that weren't documented that way the last visit. So if an auditor wants to see the changes and they want to know it wasn't cloned, they can see very clearly what was changed. They're bolded. So consider figuring out how to make it obvious what the changes were in your records, okay? And our software does it automatically. All right, so let's dive in a little deeper here. Let's take a deep dive into this S, or subjective. And what I've done here is I collected the information about what belongs in the S part of a note from all these resources, from Medicare, from private payers, and so on, state boards, and I've put them into one spot here so we can kind of break it down and try to come up with a magic template that captures everything. The subjective is the information that isn't specifically measurable. I like to say it's usually in the patient's own words, or it's best if you can put stuff in the patient's own words, and here's why. If it's quoted each time, if you ask the patient to describe something and you put it in the notes in quotes, that's always going to be different. There's no way the patient's going to use the exact same words every time. So the subjective is where you can update each complaint by location, and I've got 5 bullets there under the first bullet, which is region, severity, character, duration, and timing, aggravating, relieving factors. These are the kinds of things you put in the subjective. You interview the patient, ask them about this stuff. But it's really about changes. I don't care so much about a summary of what they told you at the first visit. If the first visit they said, I've had low back pain for 10 years, it's in this location, it's always like this. You don't have to repeat that every subsequent visit. I don't care about that so much. You can summarize it, but that's not really what I want to read in a daily visit. What I want to read in a daily visit is the change. I want to know what's changed. So one way to really clearly emphasize the change is to ask the patient to explain to you changes in function. Okay, function is really important too. So I put here in brown and in quotes an example. I can walk a few hundred yards further before the pain stops me, or I can sleep 3 hours before the pain wakes me up. So here's the magic here. Find a functional loss the patient reported through their outcome, the questions, or something like sleep or walking or lifting or doing some activity of daily living. Find something they said they've lost, and every visit, ask them about 1 or 2 of those, and ask them to tell you if any of that has changed. And if they said it didn't change, then you can put in quotes, patient states that sleeping hasn't changed. That's okay, because you're still quoting the patient and showing your record wasn't just copied and pasted from before, all right? So I'm suggesting to you to get the patient to tell you something you put in quotes, because that will make sure the notes are different every time. If you have the exact same information in the subjective findings for more than a couple of visits, it looks like cloning. It looks like the patient's not changing. So I strongly discourage you from going beyond maybe 3 visits with the exact same subjective information. Because if I was the payer, if I was Blue Cross, I might come to you and say, I am not going to pay you because you've treated them 3 times and nothing's gotten better yet. So I'm warning you that if you get to 3 visits and nothing has changed, that you need to document a reason. That's where you can put in there in your assessment, say, look, the patient hasn't changed their complaints at all, and I think it's because they missed a couple visits, or because they re-hurt themselves, or because this condition's been there for 300 years and it ain't going to change in 3 visits. You need to try to your best to explain yourself. Don't just ignore it and leave it the same. Go out of your way to give me reasons. If you're not going to change that note, if there's no improvement or progress, you better explain why. And maybe you start different. You just say, look, my treatment protocol is not working, so I'm going to discontinue care, or I'm going to send the patient to someone else, or I'm going to try a different treatment. So that's what I want you to do. So let me go further and give you an example here. So here's an example that I made up for a subjective. Mary Jane presents today for continued left-sided dull, achy neck pain that began last week after, quote, sleeping wrong. She states that, quote, it gets worse during the day, but I slept for 4 hours last night, which is the best night since this began. See, and what's great about that phrase is that won't appear in any other note. This is unique to this one note. Further, the last line, she states that the pain has improved from 6 to 4 on the verbal numeric rating scale since the last visit. If I state actual pain ratings, that's probably not going to be the same for more than a couple of visits. If I just say her pain is better, I can say that every visit, right? But if I say 6 to 4, not every visit is going to be from 6 to 4. The next one's going to be from 4 to something else. So that will ensure that the next visit is going to be different and unique, okay? All right, there's my example. I'll go through an example for each of the sections here. Here's objective, all right? So I told you subjective is best when it's the patient's own words. Objective is quantifiable stuff. So it's stuff that's measurable. It's quantifiable, okay? You can put a number on it. The more numbers you have in this section, the better, all right? So I believe that this is where you can put in findings that support various things that chiropractors do. First, you always need to support that there's segmental dysfunction. And I've seen far too many records where my doctors are doing audits. So another job that I do is I do medical record audits. If any of you are interested in having me review your records, you can contact me, and for a fee, I'll do it for you. But I'm going to let you know right now that I've just given you my secrets. This is exactly what I'm going to look for. So you can pay me to look for it, or you can just pay attention to what I'm teaching you right now and look for it yourself and fix it. You guys are welcome to pay me. I will take your money anytime, and I will just do what I'm sharing with you right now, okay? So I believe that the objective portion of a note should document that there's a segmental dysfunction. Now, Medicare guidelines for about half the country now say that they don't expect to see PART on every visit. I don't care about that. I think I expect to see it. Medicare may not want to see it, but I think it should be there because I think every visit you should justify segmental dysfunction if you want to get paid to do a manipulation, all right? So you should have some objective findings, and I think PART, which is Medicare's acronym for identifying a subluxation, is a great way to prove that a patient needed an adjustment. So I think every visit you should take a moment to do that, and I could dive into part and what that is, but we'll save that for another time. I also think that in the objective portion of a daily note, you can update any other diagnoses that you have. Maybe you've also diagnosed the patient with radiculopathy or headaches or something. You could do some other things like palpation, range of motion, stability, muscle strength and tone. Those are from the 1997 E&M guidelines, by the way, for musculoskeletal exams. That's why I chose those 4 items, because those are recognized as musculoskeletal exam bits of information by the general medical community. And this is also where you might want to do some orthoneuros, if applicable. I wouldn't redo a bunch of negative orthoneuros every visit. That would be a waste of time. But if there was one that was positive and you wanted to retest it once in a while in daily visits, I think this would be a great place to do that. This is also where you can retest the outcome assessment questionnaires, like your OSWA-3, for example, or your functional rating index. If that's applicable, I wouldn't do those every visit either, but I think that they would apply every 2 to 4 weeks in pretty much every case. And they're a great way to show progress. Here's what I need to see in the objective findings: changes since the last visit. I wish I bolded that word in the slide. You need to emphasize the change, just like you do in the subjective. I don't care so much if you say every single visit, tight and rigid muscle fibers at C3 and 4, and then you adjust through 3 and 4, or decrease intersegmental motion at T5. If you say that every single visit over and over and over again for 30 visits, one way I can look at that is that didn't change, and you're no good as a doctor. You're not able to fix it. So I don't care so much if you just want to justify that T5 needs to be adjusted. If you do, emphasize changes. Tell me if you've been able to get it to move a little differently, or the muscles have modified in some way, or the strength is improved. Tell me these things, because I need to know about change. If I want to pay you, if I have to pay you, I'm paying you to change the patient, not to just report the exact same finding over and over and over again. Okay? And I see it far too often when I do chart reviews, that they just have the same C3 is to the right, C3 is to the right, C2, lumbar paraspinal is tight on the left. Well, if they're always tight for 10, 15, 20 visits, that tells me you're not doing any good for the patient. So I want you to emphasize improvements in those things. And just like with this objective, if you copy and paste objective findings more than a couple of visits, it's cloning. So I need to see some change within a couple of visits. If you feel like, you know what, the muscles are going to be tight for 2 visits or 3 visits or for a week, I get it, that happens. But if it's for 2, 3, 4 weeks and you say the exact same objective findings, I don't think your care should be paid. And that's me being a little biased, but that's what I'm thinking. Unless you explain yourself and you say, well, the reason it's like that is because the patient works in this job where he's always lifting these boxes and twisting. There's nothing he can do to change it, and he's always re-injuring himself. So we're going to have to try some co-management with some other providers, or we're going to have to try a different treatment protocol, and that's why he's not progressing. Like, okay, then just explain yourself. And that happens in the next segment, which is the assessment. But first, here's an example of some objective findings that I think are pretty good. Involuntary muscle contraction, and I put a T there to emphasize that's the T from PART for Medicare's benefit. Involuntary muscle contraction, T for tissue, is palpated on the right from C3 to C7 with tenderness, which is P for pain, and restricted left rotation lateral bending. Right lateral bending is no longer restricted. So I've added something here that's unique. Hey, right lateral bending, that's something's better. All other segmental range of motion within normal limits. Restricted intersegmental motion is noted at these levels. So this is just, and I put the T, the P, and the R in parentheses there to show anyone who wants to see it that I've got part. I've got 3 elements of PART in there. And this is an example of, I think, acceptable objective findings just to support the chiropractic manipulation. There's not much here to support other diagnoses. That's okay, because I'm keeping this simple. What about A for assessment? All right, so I take the subjective and the objective, I add them together, and I dump them into a bucket, right? And I get my big stirring rod or a big stick, and I mix them up, and then I look into the bucket and say, what do I get out of this? I've got the subjective, I got the objective. What is it? It's the assessment, okay? And this is where I think sometimes providers are lacking here too. I've got here several things you can put in this section. You don't have to do all of these every time, but many of these should be in there for every single visit. I think this is where the diagnostic statement belongs. And I have a presentation on the diagnostic statement. I wrote a chapter about this concept for the Chiro Desk book that we'll do another time. All right, maybe the next webinar I do here for CHUSA, we'll do the diagnostic statement, because that's a great one to teach you as well. It's how to come up with a really clear, concise diagnostic statement that supports ICD-10 codes, but also ties back to your subjective and objective findings. That's also known as a clinical impression to some of you. This is where you can talk about subjective and objective progress. So maybe under subjective, I said, a patient says that they can sleep longer than 3 hours. And then here I say something about, because the patient's sleeping longer than 3 hours, that's progress. I would go ahead and take a moment to comment on it and provide my commentary, the color commentary, if you will. Objective progress. This is where I might say, hey, on the objective a moment ago, I told you that range of motion is normal in that one range. That's evidence of progress, This is where I can talk about patient compliance or lack thereof. This is where I can mention barriers to recovery or aggravating factors like their job or diabetes or something. This is also where I can take a moment and say, hey, we had a long-term goal of getting the patient to sleep 8 hours a night, and we are getting there. We are on the way, And this is also where I can emphasize the phase of care. I love phases of care because they provide benchmarks. So, for example, you might have a relief phase of care followed by a corrective phase of care. You can use your own names, whatever you think fits the way you practice. But I'm telling you, this is where I can say, and the patient is currently almost at the end of the relief phase of care. I might I might say that little phrase here. So let me give you an example of that and show you what I mean by that. Here's an example of the assessment. I didn't write out the diagnostic statement for this because I had to fit it on a slide, but I listed the diagnoses. I believe it was Meridian actually said several years ago that though it's not a specific requirement, they would love it if you went ahead and listed the diagnoses at every visit. So I did that here. I just listed 3 basic diagnoses, and then I added a little commentary. I said, patient appears to be progressing well as evidenced by, and here's a key for you guys. Here's a nugget. I would love it if your assessment in every note had the phrase as evidenced by, because you could say patient appears to not be progressing or progressing slowly or progressing quickly, and then say as evidenced by, and then finish the sentence. Tell me what evidence you have to prove that patient is or isn't progressing. I've got decreased pain reporting, improvement in sleep duration, approaching the original goal of 6 hours. Some change to right lateral bending is also favorable, so there's an objective improvement. Treatment was tolerated without incident. Short-term goals previously outlined are still expected to be achieved by the next evaluation, and as such, care should continue as per plan dated whatever. So I don't have to relist the whole plan. I can just mention that I created one previously and put it out here. So there's an example of a good assessment. Then we get to P for plans or procedures, right? And this is the final element, kind of closing it all together. This is an outline of what's next. So this is where you can take a moment and tell me what happened today, which is procedures, and then the plan is what's going to happen next. So I think most chiropractors do 4 types of procedures. They do CMT, which is chiropractic manipulation. They do modalities. They do durable medical equipment sometimes, and therapies. And I've added after that what I want to see around each of those. So for therapies, for example, I want to know the type of therapy. I want to know the location where it was provided. I want to know the time it took to do it and the rationale for why it's being done. And if you explain that well enough at the original visit, then you can just state that therapy was carried out as outlined previously. But somewhere I need to know what that is. Incidentally, in PayDC in our software, we compel you to add this information when you set up a care plan so that it sticks with the patient all the way through, so that every note will have these details in it. This is where you can talk about percentage of completion towards goals, specific and measurable goals. This is also where you can outline home instructions if you give some new ones or if you're just re-emphasizing what they already have. And this is where you outline the visit number and the date of the next evaluation. So let me show you my example of this. The following services were provided at today's encounter, right? And I've got electric stim and a chiropractic manipulation. That's all I did. So I got a description of the electric stim and where it was done and how long it was done and what the settings were and what the goal was. So I've got all that just summarized in that 2 sentences. And then I've got chiropractic manipulation, summarized there and where it was done. I've got my short-term goals of sleep and pain reporting. And then at the bottom, I've got a little summary that says patient's going to continue the care plan that we outlined, including the stretches that were taught for them to do at home on a certain date. This was visit 4 of 10. She's due to return in 2 days with a reevaluation in 2 weeks. I mean, anybody who reads this has the whole story. They don't have to ask for more records. They don't have to interview the patient or me. They've got it there, okay? So I've created this example, and some of you are looking at this going, well, that sounds all well and good, but, that's a lot of work. How do I make this simple and just make it happen? And I'll get into that. But first, I'm going to tell you something else. Medicare. Let me explain Medicare to you. They do not follow a SOAP format, and that makes me think, well, I got to create different notes for Medicare patients. No, you don't. We can use a SOAP note, and I think any competent Medicare reviewer, and I know that that's kind of a lot to ask, but a competent Medicare reviewer should be able to pull out what they're looking for. So this list shows 4 things that Medicare is looking for, and this applies to most of you. Some of you, there's only 3 things. The 4th one is sort of new, and it's only official for about half the country right now, but we expect the rest of you to have to do this as well. So basically, Medicare says for a subsequent visit, that's what they call treatment visits or daily visits, there needs to be these 4 things: history, physical exam, treatment given, and fit within the plan. And I've taken some liberty here with the words, but I'll explain each of these here. And what I've done in red there is I've shown you how this fits within a SOAP note. So Medicare has 4 requirements. SOAP note has 4 elements, but they kind of crisscross here a little bit. Medicare's requirement for history is pretty much the same thing as what I just discussed that would go into subjective. What Medicare says is part of the physical exam is what I have just outlined goes into objective and assessment. And what Medicare says is the treatment given and the fit within the plan goes into the P or plan/procedures under a typical SOAP note. All right, so I'm going to get to you guys are going to love it. I'm going to get to a template. And I'm going to show you how I bring it all together. So I think the suspense is building. Just hold on here. So what we're looking at here is Medicare's requirements for the history, their first element. And at the top, I put in red the letter of the subjective of the SOAP note that I think it fits in. So Medicare requires these bullets: review of chief complaint, changes since last visit, and system review. And I think those fit nicely under S, under a SOAP note. Okay, I would add here something you could do to make this a little more robust. For changes since last visit, instead of just saying to the patient, has it changed since last visit? And they say, yeah, it got better. You would say, well, did it get better immediately after, or is it better now, or both? Because those are different. You know how some patients feel better right away and then they feel much worse, or vice versa? So it's important to ask that a little bit more, and you can get a little more detail out of them to document those things. So there's how I believe the S in a SOAP note correlates with the history as required by Medicare in a subsequent or treatment visit. The O in the SOAP note, I think, matches up very nicely with the physical exam requirements of Medicare. So Medicare says that the physical exam is an exam of the area of the spine involved in the diagnosis. And they also let us know that you need to document subsequent changes by updating the neuromusculoskeletal exam findings. They say you don't have to do PART again, but I disagree with that. I think you should do it anyway. They say it's not expected, but I can't see how you can justify the existence of an M990 or segmental dysfunction without it. So I think you should go ahead and just document it every visit, and you can show how it changes too. If your physical exam is above and beyond the routine work done with a typical manipulation, then you could bill an E&M code with a 2.5 modifier to show that it was significant and separately identifiable. You could do that at this point instead of just getting paid for the CMT. The A in a SOAP note correlates very well with the physical exam as well. Medicare requires also during your physical exam to document the assessment of changes in patient conditions since last visit. So they even use the word assessment in there. Again, this is Medicare requirements we're looking at, and I'm trying to force them into the A in a SOAP note. So what you do here is you compare previous findings to the current. So you say, hey, they could only turn their head 20 degrees before, and now it goes 35. This is where you evaluate ongoing signs and symptoms. And they don't want you to wait until a re-eval to recheck things. They want you to do it periodically and do a little mini exam. It may not be separately billable, but it's enough for them to get the information they need to determine if your care was reimbursable, okay? And this is also where you can update the diagnoses if applicable. Evaluation of treatment effectiveness is another requirement of Medicare for the physical exam. And they just want you to go on record as saying whether or not you think this stuff is working. So this is where you acknowledge progress towards goals. You would say, patient is responding as anticipated. But I would have you add this as evidenced by, because I've seen records where they just say patient is progressing as expected. Well, but why? Why do you say that? You say, well, because I found this change in range of motion. I found that they complain less about this. This is also the place where you can put in patient tolerated treatment without incident, which is a medical legal protection for you, for them not to come back and say, I told the doctor that I was dying and he didn't believe me. And then when I died later, I'm going to sue him, So this is a great place to plant that phrase in here as well. And this is also where you can modify treatment and go, you know what? The patient isn't responding at all to the e-stim. It's a waste of time. We're not going to do it anymore. This is where you would do that. You would take that a moment to assess that you would change the treatment here. Okay, and this sort of overlaps a bit with the P or the plan there because they're changing elements of the plan. But I'm finally to the P in SOAP, which I think fits very well with Medicare's requirement to outline what the treatment was that was given and how it fits within the plan. So this is where you would say, well, we did chiropractic manipulative treatment, and we did it at this level, and we did it with diversified technique. And compensatory segments here, that would be like if a patient complains about their neck and upper back, and I adjust the full spine, I would document what I manipulated here, but they're not payable because they don't meet the criteria for medical necessity because there's no patient complaint. So I would still document what I did so it's clear in the record, but I would not necessarily bill for those compensatory or secondary regions if I'm a full spine adjuster. Okay, this is also where you should outline other treatments given like modalities and therapies. We know those aren't payable by Medicare. We know that. But they need to be listed because a note should stand alone as like the same way a script for a play does. If I hand my note over to a playwright, they should be able to reenact the scene. And so I wouldn't leave anything out because it's not payable. I would just document what really happened. And then the parts that are payable are important, and the parts that weren't payable are not important to the payer, but they're important for medical legal reasons. Okay. And I think it's safe to say, as outlined in treatment plan dated 6/12 or whatever, I don't think you have to say every single visit. In order to decrease, muscle spasm, we're going to set the megahertz to this, and I don't think you have to. If the settings are the same, just say as before, and that will also compel them to go back and look at that note that has those details and it's included. This is also where you put in the treatment number, and this is kind of an important change the last couple of years. You guys should be doing this on all your patients all the time. You should document what treatment number they're on out of a care plan. Payers expect to see this now, especially Medicare, and I would strongly encourage you to do this. Now, if that's not your treatment style, if you just see patients whenever, I got to let you know that payers are not in agreement with you. They don't care about your treatment style. They want to pay for a care plan with a designated number of visits and know where the patient is within that plan. So if you don't like doing that, you don't have to. You need to know that the payers aren't going to like you and they may not pay you. Okay? So that's how it is. That lets them know there is a plan. So what I've just done is I've taken the SOAP note and made it fit within Medicare's requirements. So Medicare's got 4 requirements, 3 to 4 requirements there, and I've shown you how it fits within a SOAP note. In other words, you can just do a SOAP note and Medicare will be happy. They should be able to spot these things in a typical classic SOAP note. I'm going to expand that a little bit here and tell you this is where I believe the part requirements that Medicare makes fit as well. Right there inside of that physical exam or the objective part of a SOAP note. I think part fits very nicely in there. And as a reminder, part is the acronym used to document the exam necessary to prove the existence of a subluxation or segmental dysfunction, all right, which I think belongs in every visit that you're going to do a manipulation. All right, so I need a drum roll here because I'm going to show you on the next slide my SOAP template. This is Dr. Gwilliam's dream SOAP note that includes all the elements for all the stuff I just went through for the past half an hour with you. All right, so this, and it's summarized here a little bit, but I believe that if I looked at your note and I looked under S and I saw a chief complaint and changes, I would feel like I got all I needed out of that. But I've given you details earlier, like I want stuff in quotes and I want to know about any changes that, anything new as well. So I go to the O and you can see for each segment that you manipulate, I want part. And then I want all your other NMS findings. And I want changes to those findings. That's what I really want to see in S and O. And under assessment, I've got 6 things listed there. You don't have to do them all, but here's some things that should definitely be in there. Under assessment, you tell me the diagnosis. You tell me about how you feel that the subjective and objective things are progressing. You talk about the patient response to care. You mention the percentage of completion for the goals. Here's where you outline complications and you say what phase of care you're in. And under P, for plans and procedures, you tell me what treatment was given. You update those goals. You tell me what home instruction was given. You tell me the visit number and outline the next evaluation date. If I see all those things in your SOAP note, I think you pretty much got it, and I'm not going to ding your records. So again, you want to hire me to do a medical record review for you? Sure, contact me. I'll give you my email, but I'm looking for this, and I would look for these things, and if one of these was missing, I would comment on it and say, hey, you didn't really mention percentage of completion towards goals. It's not a specific requirement, but it's a great idea, and it makes it really clear there's progress and stuff, so you should do that. And that's what my report would say to you, okay? So that's kind of how I would create a quote-unquote perfect SOAP note, all right? So here's an example of the daily note from PayDC. This is how we generate a note in our records. And I told you before, the stuff that's changed or bolded, and this is a paragraph layout. We're actually moving towards a list layout as opposed to the paragraph layout because it's easier in bullet lists and in tables to see what the auditor needs to see. So we're actually improving and modifying this a little bit in the near future. But it's an example of a note where you have the basic demographic information at the top, and then we go through the subjective, objective, assessment, and plan, and we can see how it appears. I bolded the changes. I've highlighted them. I want the payer or the auditor to see changes so that they don't have to come to me and say, I don't believe you. I think your patient's thing is not, there's not enough improvement. There's not enough change. Now, if those of you who are interested in it, the 2018 ChiroCode Desk Book, again, I helped write that edition, but then I left the company last fall. This was mostly Chapter 4.3 in the 2018 edition, which I think is the best ChiroCode Desk Book yet. It's updated extensively every year. I did rewrite some of Chapter 4 for them this year for the 2019 edition. I had a little bit of input into that. So I encourage you to pick it up. There's a coupon code there that'll save you 5%. So if you want to get the desk book, that's a coupon, all right? So here's what we're trying to do here today. My intention was to help you understand payer requirements so that you know what they all wanted to see in SOAP notes, which is what I would use for treatment, daily notes, subsequent visits. I wanted you to see also how SOAP and Medicare kind of correlate together so that you don't have to feel like you have to create different notes for different payers, all right? So that's what I hope I've been able to accomplish. We're at about, this is great timing actually, because I wanted to set aside some time to answer your questions. I've seen a bunch of questions come in, some of which are pretty specific. So I purposefully set aside some time for this presentation to go through those questions. Before I do, here on this slide, I'll leave this slide up for you. There's my email address. So here's the deal. You can contact me if you have a follow-up question. I'll do my best to answer it. If it's quick, if it's long and thorough, then I'll let you know what my hourly rate is, okay? I'm just being honest. I got to make a living too. So if any of you have decided that you really want to look at software and you're in the market for new chiropractic practice management program, email me and ask me about that, and I'll tell you what we can do next, okay? We can schedule a demo, and I can show it to you and talk about special pricing and all that fun stuff, okay? So contact me about that too. Now, having said all that, Christy, I would like to designate the remaining time for Q&A because I've seen some interesting ones come in, and I want to take some time to explain those.
Okay, so let's start with the first one. How did we turn from spinal stenosis to disc degeneration without an evaluation?
Just a moment here. Let me go back to that slide, actually, because you're talking about, my map, my episode of care journey. All right, so you guys are looking at the screen here now where you see this map, and you see how I suggested the patient starts up here in the upper left, and they get to a midpoint somewhere here in the center. And so the question was, well, how do they change direction? Well, maybe I outlined my first stage of care. I said, during the acute stage of care, I think we're going to do E-stim for 4 visits, and then we're going to change it up a little bit and start doing some very gentle stretches, but we're still in this acute stage of care, the first stage. So maybe that's what that turn represents. It represents that you had planned on turning after so many visits and doing something slightly different within the care. you know, and you had expected at that point in time to continue straight and go all the way to Facet Syndrome Drive, and just, you know, again, the street names are just kind of silly. But when you did the interim evaluation, you determined that you weren't going to be able to go straight. You weren't going to be able to do a certain exercise or that many therapies. You had to change your mind and go a different way. And so that's why we have that other path going down neuropathy lane. All right. So that's kind of what I was thinking when I designed this little layout. You got to be careful though. I mean, it's just a parallel. It's an allegory, if you will. And so we can take it too far. For example, let me take it too far for just a second. Let me just teach you another thing. Let's say there was a traffic circle in here somewhere. Too many chiropractors, I think, will get their patients stuck in a traffic circle where they just drive in circles all the time and they never move further towards their destination. They're just driving around and around and around, and the records look like they're just doing the same thing over and over again. And you can't prove the patient is farther down the road. What I really want to do when I create these SOAP notes, I want to document that we're a mile closer to the destination. That I'm trying to get from point A to point B, that I am closer than I was when I started. Every visit should show that they're a little closer. And if it shows for a couple of visits that you spun around the traffic circle for a little while, okay, sometimes you get lost and you get stuck in the traffic circle, but you got to get out of that traffic circle or else there's no more payment for those services. All right. So there's me going way over the top with my my allegories. Okay. So next one, Christy.
Does Medicare insist on?
Let me just say, I don't know if you guys are entertained. I'm entertaining myself here, though. I'm having a great time. So that's all that matters. I don't care if you guys like it or not, right? Anyway, carry on. Carry on.
Does Medicare insist on muscle names
regarding
palpitation? Yeah. So
you know what? I don't believe that Medicare has specific requirements for naming the muscle groups. They have specific requirements for naming the segments. So it's not good enough to say cervical region. You have to specify C5, C6. Medicare does require that. So that's something to keep in mind. I don't believe that Medicare says you have to name a muscle group. I think you could say cervical musculature and be close enough. But you know what? Just name the muscles. If you know the names of the muscles, be a little more specific. I don't think it takes much more time to name the specifics, but I don't believe Medicare requires it, okay, for muscle groups, at least for chiropractic manipulation.
If you only performed a modality or physical medicine less than 8 minutes, do you not bill or bill with modifier for reduced service and lesser fee? That's a great question.
So that is a little outside of this, but let me tell you, the deal is you don't. In 2014, the AMA clarified their codes and said, look, if you do a time-based code from these therapy codes that are 15 minutes, if you do any of these less than 8 minutes, they're not billable. The dash 5.2 that says reduced services is not appropriate. Don't do it. Do not bill. If you do 6 or 7 minutes of a time-based code, it's not billable. Unless, and here's an exception, you did other time-based codes and you dump it into the bucket and you use it to calculate total time and it brings you over the threshold for the second or third units or fourth units of time, which is another discussion. It's a little deeper, but so the short answer to that is no, you do not bill for anything less than 8 minutes. The long answer is, well, you could use the time in certain circumstances. So the answer is no, but maybe yes. Okay. There you go. That's the world of coding and billing for you. But
you mentioned billing Medicare. Okay.
Go ahead.
You mentioned billing Medicare if exam is done with E&M code with modifier 25, but is it not true that Medicare only covers CMT by chiropractic, does not pay for initial or subsequent exams?
That is exactly correct. Medicare does not reimburse for E&M visits at all. They don't require them, in fact. They require different documentation for an initial encounter and for subsequent encounters, but they do not require specifically a full-on exam that's billable separately as an E&M code. However, I believe as a standard of care, even if you look at this map I've got up here, I believe as a standard of care that chiropractors and physical medicine in general, patients' cases should be updated every 30 days, every 4 weeks, give or take. So if you don't do an exam periodically, I think that you are not properly assessing progress. Now, I've been involved in a case recently where the payer this is happening in, is this my friends in Virginia? I think this is Virginia, where they're dealing with the payer saying, we won't ever pay for an exam billed along with an E&M because it's included. And I don't agree with that assessment. I believe that sometimes the exam is a way above and beyond the little evaluation you do for an adjustment, and you should get paid separately for it. And I think that can happen at 2 weeks and then every 4 weeks throughout care. I think it's a great standard to use, and it's the appropriate way to fully assess patient progress. That's my personal clinical opinion. Payers and other reviewers may disagree with me and think that chiropractors should never get paid for an E&M, and I think that's dumb. So there you go.
How are you going to do this in a timely manner? They are paying us less and less, but requiring more and more.
All right, that's a good question. I think that one sets me up to sell you guys more stuff, right? How do you do this in a timely manner? You get a great EHR that can do it for you, that does most of the heavy lifting. You attend a couple of seminars like mine or some other experts out there, some of my good friends, and you learn more and more about what they're trying to say, so you're not guessing. You minimize things like your exposure to fee problems by partnering with ChiroHealthUSA, right? So there are answers, there are solutions out there. I like to say, and this is a little corny, but I like to say, you got to know the rules and then get the tools, right? So I just share with you the rules. Now you see there are tools in place. I mean, let me go to my other slide again. I'm going to kind of try to simplify it for you as best I could with this slide right here. I don't think that that's extremely burdensome. I mean, I know there's a lot of information in there, but I tried my best to simplify it for you as much as I could. And if you hate it and you think it's too much work, then there's other career paths, you know. I mean, and it's going to get worse before it gets better. So our challenge is to just figure out, as they continue to require more and more, how can we streamline it and still see our patients and still do what we want to do without interrupting, you know, that care? Well, we systematize. We come up with lists. We find great tools. We get the best EHR. We keep adapting and improving it. We partner with experts who can teach us and coach us on this stuff. And I think it can be done. I think that this SOAP note that I've outlined here, this template, could be done pretty quickly without you having to spend 10 minutes on a note. I think you can do it in 30 seconds with the right EHR. Okay? So that's my opinion on it. Thanks for setting me up.
With reference to part, can you please define or outline what exactly is meant by and included in asymmetry? For example, is it referring to spinal, I don't know this word, osseous symmetry, osseous, or ROM asymmetry?
Which is range of motion. So that's a good question. Here's the deal. Asymmetry is static. It's that osseous that you're talking about. It's a bone that's moved, or it's lateral translation where the head is shifted to the left of the torso or something. But the R is range of motion, and that's motion. So that's saying instead of 80 degrees, they're only getting 40. So asymmetry is a static position. Range of motion is more active. It's how far can they go, right? So Medicare actually makes it really clear what they mean by those. And I have a separate presentation where I dive into part. There's lots of great, you can find this in your LCD. So if you just Google part for chiropractors, I'm sure you can find something that explains the difference between asymmetry and range of motion for you a little bit. But an example, I might say C2 is rotated right. That's asymmetry. But if I say cervical spine is limited in its flexion, or even C2 doesn't move very freely, that's range of motion. Okay? So that's the difference.
Okay, let's see. Why do they need all of this? Most of the big changes are shown on interim exams. You cannot get all the information just from one day's note.
Beautiful. Why do they need all this? Well, that's where I'm going to go back to my map again. I don't think that the T or treatments need to stand alone. I think that they should show progress from one to the next, but they can keep referencing the initial evaluation and the date of the next evaluation. And if someone really wants to dig in whether or not that one treatment in the middle is valuable, then they can get access to the last exam and the next exam to see how it fit and how the patient got from an origin to a destination. So I think it's unfair for payers to say that a single SOAP note has to stand alone, because then you have to dump in all this repetitive information. So I think that the bare bones stuff I put in there, most of it, okay, well, some of it I guess you can leave out here and only do in the reval, like, well, I don't know, complications. For example, if you had complications and you said, look, the patient has diabetes, so it's going slower, you don't have to restate that every visit. You can restate that at the evaluations. I get that. but I think that percentage of completion towards goals, well, that could be updated every visit. You could say this visit, they're 20% towards completing the goal, and this next visit, they're 30% towards it. So I think you need to find a happy medium there. But yeah, you don't have to repeat. I don't like repetition. I don't like huge daily notes that take up 5 pages apiece. So if you feel like the information can be captured previously and it doesn't need to be mentioned again, then don't mention it again. Just mention that you did mention it previously, and reference them back to it. Cool.
Is it required, or should we document change in each visit for each section of part?
I suggest you do. I think that if I have a patient who I've treated 15 times, that my documentation of part for the third cervical vertebra should not be the same the 15th time as it was the first time. That something needs to change there. Either it goes away and comes back, or it's not as severe, or I find something different the next time. Because otherwise it sounds like you're just not changing stuff. If there's no change, you're not helping them. So again, I really, is it required? No. In fact, they don't require part to even be there now. But it's a good idea, all right? It's a good idea. And I think it's easier to support and easier to defend if you can show part and that part changes its details from time to time as you find new things on the patient.
I have some patients that have already been through a care plan, but inevitably will re-injure themselves. I don't think they need another full plan, so I just suggest that they get treated that day with sometimes a follow-up the next week. How do I write that up? Do I need to put visit number as 11 or 12? Does the insurance company really want me to put them on a 6-visit care plan when I feel like they really don't need it?
That's a good question. And I'm going to go out there and I'm going to try to pretend like I'm the insurance carrier. I'm going to say that I don't understand chiropractors as an insurance carrier, and I think that that chiropractors only see patients who have an acute injury and are going to put them on a plan with an origin and destination. And I can't understand as an insurance payer what it means to have someone who just needs a visit or two for something. Like, okay, so you need to understand that's how they see us. So I think that based on what you said, I think the best way to handle it, in my opinion, is to do a 1 or 2 visit care plan. I think that's the way to do it. I think that's appropriate, and say, look, we're just doing a care plan. I think that within 2 visits, we can restore the range of motion, remove their pain, and that's it. And we're done with this care, and I'm going to release them. I think that's totally fine and appropriate, and it still says visit number 1 of 2. I don't have a problem with that. I think that works. I don't know if that's the only way to do it, but that way seems to work for me. So,
when referencing what spinal segments were adjusted, is it necessary to specify left or right, or is documenting just the segment level sufficient enough?
So just left or right. I'm not aware of any requirements from Medicare or other payers that specify the direction of the laterality. But again, I think it's a clear way to document the A and asymmetry, right? So I think that's good to have. Is it necessary to specify left or right? I guess it's not. Okay, I'll just say it's not necessary to my knowledge, but it's not a bad idea to do so. It's funny though, I've seen records where they kind of make it sound like the patient has 2 necks, the left neck and the right neck. So make sure you're clear on what you're talking about there, so it's easier to understand. Great. So if I'm not mistaken, Christy, that's all the questions, isn't it?
Well, we had one more, I think. What is the ICD-10 code for facet syndrome?
Oh, the one I like to recommend for facet syndrome is, I can't remember off the top of my head. It's an M code that says other specified dorsopathy, and then you name the region.
M3.8, I
think. And you can email me if you want, and I can find you the code I recommend. There is no code for facet syndrome, so you have to use an other. Okay.
Okay, well, that is it for today. Just want to thank everyone for joining us today. Remind you, we have rescheduled the webinar from last week with ChiroTouch on how to set up your ChiroHealthUSA fee schedules in the software to have clean ledgers. Make sure that your everything is being documented, coded, discounted correctly and compliantly. Also, are you fraudulent and don't know it? With Paul Andrews and Mark Deviney is next Tuesday at 2:15 p.m. Eastern Time. This is going to be a great presentation on some things that you could accidentally be doing in your coding, in your software, that could be creating a problem for you in an audit situation, and you not even know it. So if you haven't already, please make sure you go ahead and go online to ChiroHealthUSA.com/webinars. You will also find all of the upcoming webinars for June, and we just started posting for July. So go on there, register early. Thank you so much for joining us today, Dr. Evan Gwilliam. I will see you soon on the road.
You betcha. Thanks, everybody.
Bye.